Thank you very much. Thanks for coming to this session. I'd like to acknowledge that this work was done on the lands of the Bidjigal people of the Eora Nation in Sydney, Australia. And we have some disclosures from the team. So we're really interested, obviously, in stigma, but really thinking about this structural element of stigma up the top of that box on the diagram, and understanding how structural stigma creates and influences and keeps going. Oh, that's not the right word I want, but jet lag just hit me again. Perpetuates stigma in organisational, interpersonal and individual levels. So there is less focus in the literature on structural stigma, and it's been described as a problem hidden in plain sight. And there's a macro turn in the literature to say, really, we should be very much looking at structural issues and not just focus, for example, on interpersonal interactions between people. So we wanted to think about this in ways that, in relation to how socio-cultural norms and discourse and institutional policies act to restrict the rights and opportunities or result in negative consequences for stigmatised people. So we did this with a case study of the blood-borne virus and STI field, and we interviewed key stakeholders who'd been around for a while and had been doing things in thinking about how to reduce stigma in healthcare. And we were using these tools of stigma power, so thinking about societal norms and these hidden, misrecognised processes that are just assumed to be there. It's just the normal way of doing things, but are really part of embedded stigma. And thinking about then the mechanisms through which stigma is produced, stigma craft. So straight into the results, we started with participants telling us about the totally important role of societal norms in setting up and maintaining structural stigma, that there are different worldviews out there based on this notion of what is a healthy, regulated body. So a healthy, regulated body, participants said, is contrasted with the views of people affected by BVVs and STIs, and those views are tainted with moralism. So this participant goes on to say it comes down basically to a judgmentalised set of behaviours that society, somewhere on the line, in its wisdom, have decided that there are bad behaviours, and therefore people who engage in those behaviours are bad, and therefore not worthy in the same way. So we're going to take this notion of this setup of societal norms and see how it influences the design and delivery of health services. So participants then said those societal norms are deeply rooted in the design, operation, delivery and evaluation of health services. So this participant saying the health bureaucrat or the policy writer or the person that's writing the legislation or designing the clinical service, they're coming from a very moralistic perspective that is informed by those societal norms of what's right, what's good, what's bad, etc. And this results in health services that are built on assumptions that don't match and work to keep out the people for whom they're supposed to care for. And this means that it creates extra work for people who deviate from those normative assumptions. They need to find ways to chisel away to find a door into the system, as regular doors are not available to them because they're in this group of the judged body. So the idea then that societal norms as stigma governance are hidden in taken for granted processes in healthcare. They're hidden within the system, they're hidden within the language. So this participant explains that as, you know, that the feeling is we're providing care for you but somewhat reluctantly. Relationships and hidden assumptions that are in those environments which are about power and control and who has influence is a really key issue. They're influential in policy decisions, and hidden biases and assumptions and judgmental attitudes are seen in this division and in the allocation of resources, which goes right to the issue of structural stigma in terms of resource allocation. So another participant gave us a different way to think about this. So they talked about going to their own family doctor and seeing signs on the walls in the clinic, and that these signs are those stigma craft. They're taken for granted assumptions of legitimacy. So on one wall, here's a sign that says, talk to us about your HIV treatments. Come and talk to us about Hep C treatments. All very welcoming and inviting. But on the other wall, there's a sign with a list of medications which are not prescribed by that service, and all of them, this participant noted, were medications for opioid dependence. Come talk to us about your HIV and Hep C, but we're not going to give you these medications. And this participant explained this to us as it's messaging to people about what's acceptable and what's not, with regards to what drugs are acceptable and what treatments are acceptable and what aren't. What the rules, policies and procedures do is affirm the norms. They say that those norms are okay, because we put them on a sign for everyone to see. Those structures, those rules, policies and procedures give the permission for stigma and discrimination, because it's also how they are interpreted. So it's a systems level, it's affirming what they're doing, which is stigmatising and discriminating. So what do we do? How do we disrupt stigma power in health systems? And particularly when taken for granted processes are normal and aligned with social values. They're literally part of our cultural wallpaper. How do we notice them? How do we see them as exclusionary? And the participants talked about the need to disrupt these ideas, to bring them to light, to reshape and maintain change in the face of status quo. And when we're talking about these big cultural norms, participants then reflected that if you're just going to give training to health workers, it's a very limited effect that you will see, because so much of what you're trying to fix is issues in isolation of broader social change, and it's very difficult to do just by training one health worker at a time. So then people talked about the importance of complaints mechanisms and centring people with living and lived experience in healthcare setting, design, delivery and evaluation. So our Australian quality standards say that every health service which is funded and accredited must have a complaint system, and that complaints received should be used to inform improvements in the service. But participants very strongly said complaints mechanisms are ineffective and harmful when the onus is on individuals who are already unwell, who might find the process exhausting and are likely to be seen as a troublemaker in the service that they rely on. Being the squeaky wheel means that people may not be able to return to the service for fear of repercussions of making a complaint. And in fact, that their complaint might be dismissed with impunity using the stereotypes, those norms. Oh, that's just one person and they were disaffected, probably drug seeking. We don't have to pay attention to them. And further, that there are protective mechanisms within health systems to stop stigma becoming visible. So obscuring what's happening with clinical jargon or organisational processes that push away the stories of individuals. And at the higher level, political need for health efficiencies that might be focused on metrics like waiting times, where these perceived qualitative or soft issues of stigma are erased by these other very much more important agendas of governance. So centring people with living and lived experience, participants really wanted to talk about that as a way to bring to light those relationships and hidden assumptions about power and control. But this isn't and wasn't seen to be a straightforward or unproblematic issue of putting people with little power into governance which upholds hierarchical structures and giving other people more legitimacy, credibility and validity. So again, people talked about stereotypes being used to disempower, reinforce differences and distance, and draw on those norms of moralism and disgust around BBVs. So this participant saying, where a peer or someone with lived and living experience challenges the norm, it becomes a tension point. That credibility gap gets triggered when people think, well, of course you would think that because you're a gay man who has gay sex or you're an injecting drug user, of course you would think that. That's the automatic sidelining of the views, which gets back to that starting point of, do you think that drug use is okay? Do you think and feel okay about sex work? You feel absolutely neutral about gay men and the sex that they have? So to think about governance roles where people with lived and lived experience are in decision-making positions, again, these ideas of hidden processes within that system that could work to maintain normative power relations. So I love this quote because I've seen it in real life numerous times. People with lived and lived experience are invited to a policy table, but there's one of them And as the participant said, there's 5 clinicians at the same table. So how does someone who's already on the outside, not within the system, gain a voice when they are literally outnumbered? People are asked to go through difficult and stigmatising administrative processes like criminal record checks to be part of these governance systems, and they're not supported to effectively engage in governance systems. They're just expected to know these things, particularly when they're asked to do this for services where they've been systematically excluded as consumers. So participants saying, how much training and professional coaching do consumer representatives get in the art of advocacy and the art of policy making? And how well do they know the health systems at a broader sense? And how can we better equip them with those skills to be more powerful in the positions where they might find themselves? I'm going to skip that one for time. So going to the discussion, we really wanted to think about stigma at that macro structural level and see past the clinical interaction stigma between the service user and the service provider. We need to think about how societal beliefs and health systems mutually make up each other. They are not separate and distinct. They are built, health systems are built on these societal beliefs. And if we're going to challenge stigma sustained by societal norms, we need to think about the natural order and the usefulness of that natural order and assumption to dismiss stereotypes of illegitimacy, meaning that this is going to be a long process of struggle requiring multiple modes of action. Just going to move on. So yes, in Australia we have quality standards that are focused on equity and access. These quality standards are really important. Health services are accredited by them and funded if they are accredited. It is a vital strategic lever that we need to learn to pull better in advocacy for structural stigma change. And in doing this, we have to be aware of the very porous boundary between the rest of the world and the health system. It is not separate to it, it is entirely informed by these normative beliefs that are based on these taken for granted understandings of the way things work, which are often fed by moral judgments. And we need the critical analysis that various disciplines can bring, and particularly the expertise of people with living and lived experience. My final point is the complaint systems as currently set up are experienced as hostile and harmful, and they shouldn't be. There's a literature about new collectives, community-controlled processes of taking charge of complaints mechanisms. We're doing consultations on this right now to be able to build a new community-controlled complaints mechanism in the HIV sector that might allow individual redress and collation of information for advocacy for structural reform. And if you fancy a trip to Sydney in November, we're running a conference on stigma. We'd love to see you there.
Shameless.
Shame.
Thank you so much, Carla. Just stay there a moment. We've got about 2 minutes. I just wondered if there's any quick questions, because it's a very short time at the end. So just in case there's a question now. I can't see anything on our Q&A here. No? Oh, there's one over here.
Just a moment.
Thank you. That's all right, Carla. Just put you on the spot.
Yes, sure.
Thank you. Sean Faladi from Baltimore. Stigma in healthcare is such a barrier. What do you think is the solution?
So we're currently developing a trial where we're trying to reduce the silos, because we're all very exercised about drug stigma or hepatitis C stigma, but there is so much more out there. And in our conference, another plug, we've got sessions on abortion stigma, lung cancer stigma, weight and diabetes stigma, LGBT stigma. So if we keep saying, well, you've got to pay attention to us over here in this corner, we'll never get anywhere, because there is just no capacity for a health system to respond to what's been counted as 93 different identities, conditions and practices. So can we build a more universal approach to stigma reduction that's based on existing precepts in our health systems of quality care, and link that to those structural levers that are so important, because that's where the money flows?
So I've got a quick little comment.
You need to be
pass me
really
the microphone.
quick.
15 seconds. Great presentation. What about stigma by association? So that's rife in Australia.
Yes, including for health workers, and
100%.
we've done some work with people working in needle and syringe programs who are literally spoken about by their colleagues as doing the devil's work. So it is absolutely part of that.
Even in our big colleges
Yes.
our big training colleges.
Yes. And see, yes, I'll stop because our time's up.
Yeah, time's up. Thank you very much, Carla, for keeping your eye on the clock. Thank you.